All right. Well, good evening, everyone. Thank you for joining us tonight on Crohn's and Colitis Foundation's Professional Education webinar series. Our topic for this month is health maintenance for your pediatric patients. You can also find topics for next month and future month on our site, crohnscolitisprofessional.org. I'm Sudha Sarod. I manage professional education programs here at the Foundation, and I'm very excited to turn it over to Meredith McIntee, who will be the moderator for tonight's webinar. So Meredith, on to you.
Thank you, Sudha. Hi, everyone. Welcome to our Pediatric IBD webinar focusing on health maintenance. As she said, my name is Meredith McIntee. I'm a nurse practitioner in pediatric GI at the University of Chicago's Comer Children's Hospital. And my colleagues Teri Jackson and Whitney Gray will be your presenters tonight. Whitney Gray is an IBD nurse practitioner at UPMC Children's Hospital of Pittsburgh and the current co-chair for the Nurse and Advanced Practice Provider Committee of the National Scientific Advisory Committee of the Crohn's and Colitis Foundation. And Teri Jackson is a GI nurse practitioner at Orlando Health Arnold Palmer Children's Hospital and serves as the co-lead for the pediatric work group for the Nurse and APP Committee of the NSAC. So with that, we'll get started. This is our agenda. We have no disclosures. And these are our objectives. So according to the Crohn's and Colitis Foundation, approximately 3 million Americans have IBD, with roughly 70,000 new cases being diagnosed each year in the US. IBD is most often diagnosed between the ages of 15 and 35, but can occur at any age. And it's estimated that there may be as many as 80,000 children in the US with IBD, and there's evidence of increasing incidence. And a recent Canadian study reports that a 7.2 per year increase in children diagnosed with IBD before the age of 5. So children and adolescents with IBD have the same general health recommendations as those without IBD, but there are additional special considerations because of the nature of the disease processes and the medications used to treat it. So of course, the general health maintenance considerations include topics like growth and development, immunizations, routine surveillance for health complications, and provision of health education, promotion, and anticipatory guidance. And Teri and Whitney will go into each of these topics in greater detail, but the special health maintenance considerations for those with IBD include screening for nutritional deficiencies, lab abnormalities, bone demineralization, vision problems, tuberculosis, cancers, and mental health issues, and proactive conversations about smoking cessation, substance use, and sexual health. And now I will turn it over to Teri Jackson.
Good evening. We have probably all seen growth charts that look a little like this, whether it's a growth chart for height or weight or for BMI. Kids oftentimes will come to see us as they've started to plateau off of the growth chart and fall off of the growth chart. It's oftentimes at this point when they get diagnosed with inflammatory bowel disease and get started on medication management, nutrition management, or enteral therapy with some improvement in those factors. It is estimated that somewhere between that growth failure is a presenting factor in 15 to 40% of children with Crohn's disease, 3 to 10% of children with ulcerative colitis. And it's also estimated that 19% of children with Crohn's disease will achieve an ultimate adult height at least 8 centimeters less than their expected growth. For those reasons, the NASPGHAN Foundation has made the recommendation of height, weight, and BMI measurements that should be done during routine office visits, and that certainly includes health maintenance visits. Their recommendations are our patients during quiescent periods should be screened at least every 4 to 6 months, and during active disease or those who have risk factors for nutritional risk or for growth delay should be done more frequently. Additionally, Tanner staging should be done in girls starting at the age of 9 and boys at the age of 10. The Improved Care Now Network has created documents that will help to us in our assessment of growth and nutrition in our patients. They have categorized our patients for those who are doing satisfactorily, those who are at risk, whether it's from mild malnutrition or moderate malnutrition or at risk for growth failure based on Z-scores. They also have categorized patients for failure also based on Z-scores. For the first time, they've added obesity as a risk factor for growth and development, because as many as 15 to 40% of pediatric IBD patients may be overweight or obese. What we know about obesity in pediatric IBD, or in general IBD, is that the increase in visceral fat oftentimes can increase the risk of penetrating or stricturing complications of Crohn's disease. The failure of biologic treatments thought to be secondary to increased drug clearance or shorter half-life, low trough level attainment, as well as impairment of the absorption of subcutaneously administered modules. Having obesity has an increased risk of inflammatory burden that further complicates the inflammatory bowel burden of inflammatory bowel disease. We also know that post-surgical complications are more frequent in those with Crohn's disease and ulcerative colitis who are obese. The Improved Care Now network also categorized patients who are after puberty, because at that point in time, they're not going to grow anymore. Based on those care stratifications, interventions have been put into place. In general, those interventions include dietary counseling, dietary referrals, increasing calories through supplementation, consideration for reassessment of disease status, as well as considerations for escalation of therapy depending on their risk factors. They also make the recommendations for consideration for referrals to other specialists to help in our patients' cares. In general, they give recommendations for follow-up for those patients. For those who are at risk, whether it's mild or moderate nutrition, the recommendations are to follow up in 2 to 4 months. For those who are in failure, to follow up every 2 to 4 weeks. For those who are obese, every 2 to 4 months. And for those who are at risk for growth failure, every 1 to 2 months. I've included here some great resources for educational materials that we can share with our patients and families. The eatright.org is general information, not just for inflammatory bowel disease, that's very helpful to our patients and our families. One of my favorite ones now is Nutrition Therapy for IBD. This website has incredible information about nutrition, nutritional supplements, and different diets for IBD. It is written by patients, parents who have IBD, parents of patients who have IBD, as well as patients or people that may have family members with inflammatory bowel disease. Additionally, the Crohn's and Colitis Foundation has other great resources for information about diet, nutrition, and inflammatory bowel disease for children. We all do laboratory studies in the monitoring of our patients. Common laboratory studies are CBC, CMP, hepatic function et al. And Aspergen makes the recommendation that during quiescent disease, that these labs should be done at least every 6 to 12 months. During active disease, or if they are abnormal, they should be done more frequently. In preparing for this talk today, I found that for vitamin and mineral deficiency, there is no consensus among the groups. In this particular recommendation from Fritz et al., they wrote an article talking about systemic review of micronutrient deficiencies in pediatric IBD. Their recommendations are that iron studies, vitamin D, and zinc studies, which are the most common abnormalities, should be done at diagnosis as well as annually. But they also recommend the B12 and folic acid not be routinely done. Well, that's absolutely in contrast with recommendations from the IBD work group recommendations. They recommend B12 and folic acid levels on all IBD patients, as well as screening every 3 to 6 months for those who have excessive ileal disease or resection ileopouches, or those who have bacterial overgrowth. So what are we supposed to do from that standpoint? Perhaps the best guidance may come from Lee et al., who makes the recommendations of doing a vitamin D level at least every 6 to 12 months. Well, why vitamin D? We think about vitamin D from the standpoint of bone mineralization and calcium absorption. But what we now know about vitamin D is it also has antioxidant and anti-inflammatory properties. Recent studies seem to show that with inadequate vitamin D, with appropriate levels of vitamin D, it can reduce the risk of relapse through the inhibition of pro-inflammatory cytokines. It also decreases inflammatory markers. It improves the Crohn's disease activity scores, and it also preserves the intestinal barrier wall and function. In other words, it causes tight junctions. With the other vitamins and minerals, they're listed as being conditional. When I think of conditional, I think of it as meaning we should be using our critical thinking skills. For patients that are at risk for iron deficiency, and those patients are those with evidence of anemia, with blood loss, with fatigue, or with pallor, iron studies should be done. For those with macrocytic colitis, macrocytic anemia, history of ileal disease, ileal resection, ulcerative colitis patients that have had colectomy and have had an ileal pouch placed, people that are on a vegetarian or vegan diet, B12 levels should be checked. Folic acid should be done for those that are on methotrexate or sulfasalazine. Excuse me. And for those patients with B12 deficiency, if you're trying to supplement them and you're not seeing any difference, check a methylmalonic acid or homocysteine level. That can help to clarify whether it's truly vitamin B12 deficiency versus folic acid deficiency so that you can treat them appropriately. When I look at calcium, zinc, magnesium, phosphorus, these are mostly abnormalities that can occur because of severe diarrhea or persistent diarrhea, increased ostomy output. For zinc levels, kids that may have recurrent skin rashes or fistula should be considered for monitoring zinc. If you have laboratory studies that show that there is a low alkaline phosphatase, make sure you check a zinc level because sometimes the low ACPHOS can be secondary to zinc deficiency instead. I think of magnesium and phosphorus for our kids that may have severe malnutrition, that we're in the process of trying to improve their nutritional status through feeding them, that may be at risk for something called refeeding syndrome. By using our thinking caps, we can then make recommendations for treatment. The general initial treatment should always be dietary measures. Having diets that are high in those vitamins and minerals that they may be losing is the first priority. But for those who cannot tolerate those dietary measures, using multivitamins with iron or with minerals may be comparable. For those with significant defects, checking or giving medication, giving the vitamins and minerals that are specific to their deficiency is important. We're going to later talk about vitamin D and iron separately. So here I've included some resources that will also help with information for our patients as well as for ourselves about vitamins and minerals. This is the NIH.com website that gives incredible information about vitamins and minerals, including dietary measures as well as supplementation, both for healthcare professionals as well as for patients and for families. So I said we were going to talk a little bit about iron deficiency. Well, iron deficiency is probably the most common deficiency in patients with inflammatory bowel disease. Somewhere between 30 and 88% of children with IBD may present with iron deficiency at some point in time. The Iron Deficiency Task Force has recommended universal screening with a CBC with differential indices, ferritin level, TSATs, and reticulocyte count be done every 6 months for those with inactive IBD and every 3 months with those with active disease. For those who are found to have iron deficiency with active disease, iron can be replaced orally, and the dose of oral iron is 3 to 6 milligrams per kilogram. If they're not able to tolerate it, then they should get IV iron. For those who have iron deficiency with severe or active disease, they should also get iron IV. The dosing for iron should be determined based on the total iron deficit. So this is a mathematical calculation that helps to give you an idea about how to calculate out the deficit so that you can replenish the iron appropriately. For those of us who are not mathematically savvy, there is a website that you can plug in your numbers and it will automatically calculate out the iron need that you have. For kids that are treated for iron deficiency, reassessment should be done by repeating a CBC and a reticulocyte count in 4 weeks. So vitamin D, we already talked about the importance of vitamin D. The normal vitamin D level should be at least 30 nanograms per milliliter. Here I have the doses of calcium and vitamin D that should be given to patients who have normal vitamin D levels. That vitamin D can be given by dietary measures, high in calcium and high in vitamin D, or it can be supplemented orally. So this is the RDA recommendations for kids based on their age. This is the upper limit of maximum. So these are limits that if you need to give more, that these doses can be given without complications. For vitamin D, that these are the recommended doses, and these again are the upper limits of normals that can be used. So vitamin D insufficiency is a vitamin D level of between 20 and 30, and obviously the doses are listed based on whether it's mild insufficiency or significant insufficiency or moderate insufficiency. And as you can see that these doses are far within that maximum dose range listed above. And for vitamin D deficiency, that's a vitamin D that's less than 20, or severe deficiency of vitamin D that's less than 10. For those who have a vitamin D less than 20, 50,000 units internationally, given weekly for 6 to 8 weeks, is often enough to be able to correct the vitamin D status. For those who are less than 10, 50,000 international units given for 10 to 12 weeks is enough to help to correct that. But sometimes our patients aren't necessarily as adherent with taking medicines as they're prescribed. So there's something that's called STOS dosing. STOS in German means bump or push, and it's sort of a push start to getting vitamin D levels up. It is by giving a high dose of vitamin D. And when I say a high dose of vitamin D, that's somewhere between 100,000 and 800,000 units given as a one-time dose. And what studies have shown is that giving a STOS dosing of vitamin D can increase and normalize the vitamin D level in our patients for up to 6 months. Recently, Lee et al. Did a study looking at patients with vitamin D deficiency. Half of the patients got STOS dosing of 300,000 units of vitamin D as a one-time dose. The other half got 50,000 units weekly for 6 weeks. At the end of 12 weeks, they checked the measures on both patient populations, and they were comparable. So both dosing regimens seem to work well and can be safe to use. With STOS dosing, concern has previously been that you're going to cause hypervitamin D-osis, or you're going to cause increased calcium levels or increased phosphate levels, or that you may even have complications with PTH or the development of renal stones. And none of the studies that I have listed on the slide were those found in patients getting STOS dosing of vitamin D. So why do we also think about vitamin D? We think about it because of bone health. There is no consensus as to when or how often you check DEXA scans on patients. I think in general, DEXA scans are usually recommended with patients that may have risk factors. And that follow-up is based on those risk factors and the results that you get. So in thinking about what those risk factors are, those risk factors include a course of severe IBD, particularly with people that have hypoalbuminemia, those who have had continuous steroid use for more than 6 months, those who have had suboptimal growth, poor weight gain, pubertal delays, primary or secondary amenorrhea, and those who have a history of low trauma fractures. So what do you do with the results? The results should be recorded as Z-scores. Z-scores as opposed to T-scores. T-scores are comparing the results with those of a healthy young adult cohort between the ages of 20 and 35. A Z-score compares the bone density with those of an age, gender, race, and ethnic cohort for better comparison. So what do you do with the results after that? They are read as being a Z-score of plus or minus 1 as being normal, a Z-score of less than -1 to -2.5 as being at risk for low bone density, as less than -2.5 as having low bone density. You may notice that I did not say osteopenia or osteoporosis. The terminologies are not recommended to be used in pediatrics. For low bone density, the recommendations for those with low bone density, osteopenia, that terminology osteopenia, connotes the evidence that there have been fractures also involved. So when you get your results back, what do you do from that standpoint? So for those who have normal DEXA scan preventative measures, that includes making sure that you have a diet that's rich in calcium and vitamin D, supplement as you need to, increase the use of weight-bearing exercises to increase bone growth, do some preventative measures such as avoiding smoking and alcohol, and making sure that we reduce steroids. For those who are at risk, you want to do the preventative measures, but you also want to consider repeating a DEXA scan in at least 2 years. For those who have low bone density, these are patients that may need to be monitored with other subspecialists that are experts in bone development or endocrinology. You also may want to consider evaluation for other non-GI causes of their low bone density, and that the point that I wanted to also make is that biphosphates are not recommended for use in children. Biphosphates, well, in children have rapid bone growth. And because they have rapid bone growth, the concern is that by adding biphosphates, that it's going to cause abnormal rapid bone growth in our children. The only time when biphosphates are recommended for pediatric patients is when there's evidence of vertebral fractures, and those biphosphates should then be orchestrated by an endocrinologist or a bone specialist. So switching gears a little bit, tuberculosis screening. Obviously, our patients need to get tuberculosis screening at the time of diagnosis, as well as prior to the initiation of immunosuppressant medicines or biologics. And they should be repeated for those who are immunosuppressed on biologics or immunosuppressive medicines. They should be repeated annually. We should also consider repeating TB screening for those who may have risk factors or symptoms of tuberculosis as are listed here. Skin prevention, skin cancer prevention, quite honestly, is more geared toward avoidance and protection. Our kids should be using sunscreen, which has an SPF of at least 30 or greater. They should wear sun protective clothing. They should seek the shade when they can, as well as avoid or limit activities outdoor between 10 a.m. and 4 p.m. They should also avoid tanning booths. For surveillance, we should be looking at our patient's skin for manifestations of their inflammatory bowel disease, manifestations such as psoriasis or erythema nodosum or pyoderma gangrenosum et al. We should also be checking for any changes in moles or freckles that they may have. Dermatology referral is essential for those who have new or suspicious skin lesions, for those who are on immunosuppression, whether it's biologics or immunomodulators, and they should be seen annually, as well as if for those who have had a history of skin cancer, they need to be seen at least every 4 to 6 months. Eye examination should be done every 1 to 2 years. Colon cancer prevention should start 8 to 10 years after the time of the initial presentation or symptoms or diagnosis for those with ulcerative colitis and those with Crohn's colitis that involves at least 1/3 of their colon. Cancer screening should be repeated every 1 to 3 years. For those with primary sclerosing cholangitis, annual to biannual colonoscopy with biopsies for cancer surveillance is important. And lastly, cervical cancer prevention. In the past, there's been some confusion for pediatric IBD patients as to when they get screened, how often. Sometimes the recommendations were conflicting. Currently, the recommendations are that females in the general population, and that includes our females that are not on immunosuppressant medicine, should start getting cervical cancer screening starting at the age of 21. If that screen is negative, then they can get screened every 3 years. For those who are immunocompromised, that includes our patients on biologics and immunosuppressant medicines, they should get annual cytology screening starting at 21 years of age. And if negative for 3 years, then they can go to every 3-year surveillance. Perhaps the most important thing is primary prevention through HPV vaccination. With HPV vaccination, it is decreasing the risk of cervical cancer for women in the general population, as well as those with IBD. With that in mind, I'm going to transfer over to Whitney, who's going to talk more about vaccines as well as other health maintenance issues. Whitney?
Thank you so much, Teri. So first, I'm going to talk about immunizations and checking titers. So it's recommended that hepatitis B and measles titers are checked, especially if the vaccine history is unclear. So if the hepatitis B titer is negative, a 3-dose series is generally what's recommended. However, you can consider rechecking the titer about a month after the first dose. And there's been some evidence that almost 80% of patients seroconvert after the first repeat booster is given. And so at that point, if it is adequate, no further vaccination is needed. But if it's inadequate, continue to provide the total 3-dose series. So if the measles titer is, can you go back?
Sorry.
Thank you. If the measles titer is negative, consider revaccinating, but as you know, this is a live virus vaccine, so we need to consider which therapies we're starting next before giving this measles booster. And then post-vaccination varicella titers are not recommended to be checked, as the commercial assay is not entirely reliable detecting immunity, and it can lead to false negative results, which then lead to unnecessary revaccination. Next slide, please. So inactivated vaccines are never a concern and are safe for those on immunosuppression and should be administered as per the CDC vaccination schedule. And that includes the inactivated influenza vaccine yearly. Next slide, please. So for live virus vaccines, there is some more to consider. So live virus vaccines should be administered at least 4 weeks prior to starting immunosuppression. So if we're thinking about giving that measles booster, if they're non-immune, we will need to wait at least 4 weeks prior to starting immunosuppression. And then if there's an opportunity to give the vaccine after that, they would have to be off of immunosuppressive therapy for at least 3 months before a live virus vaccine is given. However, if they're on steroids, it only needs to be a minimum of 1 month after the steroids are discontinued to give a live virus vaccine. Next slide, please. And then talking specifically about some additional vaccines that are specific to our patients, so the pneumococcal vaccination. So in pediatric patients, so those greater than or equal to 2 to 18 years of age, if they've never received PCV13 specifically. So PCV7 does not count here. They are recommended to get 1 dose of PCV13, followed at least 8 weeks later by PPSV23, and then a second dose of PPSV23 should be administered at least 5 years later. Next slide, please. And then this is a new update for adults, so 19 to 65. And I know we're talking about pediatrics here, but I know many of us still continue to see patients into their early 20s. So if they've never received a pneumococcal vaccine, and it's specified again, it's PCV 13, 15, 20, or PPSV 23, so not PCV7. There are 2 options. So they can either get 1 dose of PCV 20 if that is available, or they can get 1 dose of PCV15 followed by a dose of PPSV 1 year later. Although they also note that it just needs to be a minimum of 8 weeks in those who are immunocompromised. So many of our patients, 8 weeks should probably be reasonable. And then if they did receive PPSV 23, but never a PCV 13, 15, or 20, they again can either receive PCV 20 or receive PCV 15 at least 1 year after their last PPSV 23 dose. And so no need to give an additional PPSV 23 if PCV 15 is used. And then if they've only received PCV 13, kind of similar to what we've done in the past and what we continue to do in pediatrics, the PPSV 23 is recommended at least 8 weeks later. And then, and again, in 5 years, if they continue to be less than 65, which most of our patients should be. And they don't have any recommendations at this time on giving PCV 15 or PCV 20 if they've already received the 13 and the 23. Next slide, please. So I want to talk specifically about the HPV vaccine because, again, there's some specific considerations to keep in mind for many of our patients. So in the general population, HPV vaccine is recommended for all females and males beginning at age 11 to 12 years. And if they get the series started before their 15th birthday, they only need 2 doses. However, they are recommended to get a 3-dose series if they're immunosuppressed, or they start the series after their 15th birthday. So this is just something to review with families because they might not realize that they're still recommended to get 3 doses if they're immunosuppressed. Next slide, please. And I just want to include some additional talking points around the HPV vaccine because I feel like there's lots and lots of questions around this. So the big thing is that it prevents cancer. So we know that there's an increased risk of high-grade cervical dysplasia and cervical cancer for our patients with IBD who are immunocompromised. And there's also an increased risk for HPV-associated nasopharyngeal and gastrointestinal cancers in patients with IBD. So just to give that additional information to our patients so they can make informed decisions. Next slide, please. So talking about the COVID-19 vaccine. So I'm not going to spend a lot of time going over the general recommendations today, but you can review those to the left of the screen. But I want to talk specifically about those who are moderately to severely immunocompromised. And as we currently know, the vaccine is not approved in the 6 month to 5 year group, but those for 5 to 11 years old, the Pfizer vaccine is recommended, 3-dose series, 2 doses separated by 21 days, and then a 3rd dose at least 28 days later. The booster vaccine of this vaccine is not recommended in this age group. But for the 12 and older patients, a 3-dose series again is recommended, 2 doses separated by 21 days, and then a 3rd dose at least 28 days later. And for this group, a booster is recommended at least 3 months after their last primary dose. And then for the patients that are 18 and older, they can receive the Moderna vaccine. And that is recommended, again, as a 3-dose series if you're moderately to severely immunocompromised, separated by 28 days. And then again, a booster at least 3 months later. Next slide, please. So I'm going to shift gears a little bit and talk about sexual health and first sexually transmitted infection. So with our patients, we are always concerned about minimizing their risk of infection because of being immunosuppressed. And if an active infection is going on, we often delay or hold immunosuppression. And I think it's also worth noting that sometimes sexually transmitted infections can symptoms can be mimicking of IBD symptoms, such as oral ulcers or pelvic pain. So just making sure we get a good history to make sure we're addressing the concerns appropriately. Next slide, please. And so moving on to reproductive consideration. So in women, methotrexate is a teratogen. So if a woman is on methotrexate and is considering having a family, that has to be discontinued 3 to 6 months prior to trying to conceive. And so if they're not trying to have a family, they should be on 2 forms of contraception as well as folic acid. And then prednisone we never like anyway because of all the risks associated with it, but it is a moderate risk during pregnancy for things such as oral facial cleft, adrenal insufficiency, gestational diabetes, premature rupture of membranes, preterm birth, and infant infections. And so for men, methotrexate can also decrease sperm quality, and they are recommended to discontinue it 3 months prior to trying to have children as well. And for both of these, all of these medications, when we're trying to discontinue them, we want to make sure that they have another treatment plan in place. We don't want to have a flare happen. And then sulfasalazine as well causes oligospermia, reduced sperm quality, and alteration in morphology of sperm. Next slide, please. So contraception. So if a patient isn't interested in having a family, how can they prevent unintended pregnancy? So the combined OCP is associated with developing IBD, but not a risk factor for flares. And just to kind of review quickly, the combined OCP contains estrogen and progesterone. And so we know that separately, the combined OCP increases risk for VTE, and separately, a flare of IBD increases risk for VTE. So theoretically, when those 2 things are happening at the same time, there's an increased risk of VTE. So just something to counsel our patients about. Additionally, there was a study out of Europe that looked at combined OCP use, and if patients were on it for greater than 3 years, it was associated with increased risk for surgery and Crohn's. So again, some discussion points around choosing which contraceptive. Next slide, please. So I wanted to show you this chart if you haven't seen this before. So the U.S. medical eligibility criteria for contraceptive use is a really great chart that lists all different conditions and what the risk versus benefits are for different contraceptives. So this is the one obviously specifically to inflammatory bowel disease. And as you can see, the copper IUD, the progesterone-only IUD, and the implants have no restrictions. The Depo-Provera injection has a 2, and that's because, as Teri talked about earlier, we worry about low bone mineral density in IBD, and additionally, there's some association with the Depo-Provera and low bone mineral density. So just something to consider there. And the progesterone-only pill is given a 2 because there's concern with inflammation impacting absorption. And then the combined hormonal contraceptives, as you can see, they're not a 4, so they're not an unacceptable risk. They're a 2, 3. So if someone has more mild disease, it's not unreasonable to recommend that or suggest that to them. But as we talked about earlier, there's that concern with blood clot risk as well as increased risk for surgery and Crohn's. So shared decision making. Next slide, please. And I wanted to include some resources for patients. So many centers have adolescent medicine, and they've always been a great resource for me when I have questions regarding sexual health and reproductive concerns, of course, Planned Parenthood. And then these are some websites for patients. Bedsider.org does a great overview of the different contraceptive options, risk versus benefits, and youngwomenshealth.org and Young Men's Health site are also great for addressing these concerns for patients as well. Next slide, please. So mental health. So routine assessment of mental health is recommended in patients with IBD because we see from the statistics down below that the prevalence in pediatric IBD is 16.4% for anxiety symptoms and 15% for depressive symptoms. So we want to make sure that we're assessing for this and making appropriate recommendations to help address these symptoms. Next slide, please. So I just wanted to kind of talk briefly about why there might be an increased risk with IBD. So there's studies that have shown that acute psychological stress increases serum and mucosal inflammatory cytokines. And in small studies show that antidepressants and counseling are associated with reduced steroid use and fewer relapses. So that brain-gut connection is definitely present. Next slide, please. So I wanted to include some mental health resources here. So many centers have behavioral health services as part of their centers or in the community that are awesome to refer patients to. There's also some summer camps specific to patients with IBD. So the Crohn's and Colitis Foundation has Camp Oasis, and Serious Fun camps often have a GI week. And these are camps across the country. Prove Care Now has a patient advisory council that patients can get involved in and connect with other patients. And the Crohn's and Colitis Foundation also has the Power of Two peer mentoring that 10 to 17-year-olds can participate in with parental consent. And then many Crohn's and Colitis Foundation chapters have support groups that meet either virtually or in person. Next slide. So moving on to talk about substance use, first I want to talk about tobacco. So it's, I think, well recognized at this point that smoking increases risk of disease complications and need for surgery in Crohn's disease, and current smoking and secondhand smoke exposure increases risk for colon cancer. And then ulcerative colitis, kind of an interesting story, not fully understood, but current smoking is associated with more mild disease course. However, prior smoking before disease onset, especially heavy use, is associated with increased hospitalizations, need for colectomy, and colon cancer. And plus, we know that smoking impacts heart and lungs. So just to kind of give that additional information specific to IBD. Next slide, please. So I also want to talk about vaping because, as you can see on this slide, e-cigarette use has increased about 900% among high school students from 2011 to 2014. And I couldn't find any evidence specific to IBD, but we do know that nicotine use during adolescence can cause effects such as addiction, reduced impulse control, decreased attention cognition, mood disorders, and harm the developing brain. Furthermore, e-cigarette aerosols have been shown to have carcinogens and toxic heavy metals. So providing this education and asking the questions of our patients is important. Next slide, please. And then with marijuana use, there's a lot of interest in marijuana and IBD. And so this study was of a pediatric IBD clinic of patients 18 to 21, 53 patients were surveyed, and 70% reported marijuana use, and 70% also did not discuss that with their GI. So we need to ask those questions. And then only 50% knew about possible side effects. Additionally, in the past 12 months, a study showed that 40% of 12th graders used marijuana in the past 12 months. So definitely being used frequently, and we need to ask our patients about it. Next slide, please. So I want to talk specifically about how it impacts IBD. So it seems to help with symptoms. So nausea, abdominal pain, poor appetite, and sleep. And even in mice and rat models, of cannabinoid compounds, 24 different varieties, seem to show some benefit in reducing colonic inflammation. However, there's no study available that shows improvement in biochemical markers or mucosal healing in humans. Furthermore, a study of 300 patients with Crohn's disease who used cannabis for more than 6 months had increased risk for surgery. Additionally, with marijuana, there's increased risk of car accidents and cannabinoid hyperemesis syndrome. So providing this information to our patients can help them better make informed decisions. Next slide, please. So with alcohol, alcohol is harmful to the gut barrier function, and a study of alcohol use among 403 patients with chronic conditions aged 9 to 18, 100 of them had IBD. 53.1% were unaware that alcohol can interfere with their medications. So I think about, methotrexate, we're worried about hepatotoxicity and combined with alcohol, plus metronidazole can cause kind of that reaction with alcohol as well. And then 37.2% were unaware that can interfere with labs. And then alcohol is associated with increased disease activity, specifically alcohol with high sugars, which you can think about causing more of like an osmotic diarrhea or with sulfates. So we know that sulfates are in a lot of processed foods, and we know that processed food seems to be linked with contributing to inflammation. So next slide. So here are some overall health maintenance resources. So the Pediatric Health Maintenance Technical Guide is available on the Crohn's and Colitis Foundation website. This one's obviously pediatric specific, but this other one, the Cornerstone Health Checklist, is adult, more focused, but it does provide a nice one-page checklist to kind of keep track of everything. So next slide. And here are our references, and thank you for listening in.
Thank you, Teri and Whitney. So if any guests have questions, you can feel free to submit them either in the chat or the Q&A box, and we'll address those for the next few minutes. While waiting for those to trickle in, I have a few questions myself. Teri, are there any special considerations or resources that you utilize when having a conversation about weight management with your patients with both obesity and IBD? You're muted, Teri.
I'm sorry about that. In our practice that we are lucky that we have some dietitians that help to work with us. And as part of our therapy for our IBD patients or any pediatric patient that has obesity, we really stress the importance of dietary measurements. And one of the things that we oftentimes will use is what's called the My Plate method, which gives an opportunity for our patients to be able to have increased fruits and vegetables to their diet, maybe decrease in making sure that they have a protein, make sure that they have carbohydrates on their diet. So obviously, if we're trying to increase fruits and vegetables with someone that has inflammatory bowel disease, that may not be tolerated quite so well. So our dietitians really work hard with them to be able to help to find a dietary regimen that will be helpful for weight loss. Probably one of the most important things that we also talk to them about is decreasing screen time, that we talk about no more than 2 hours of screen time during a day, and that's computer time for homework if we can. That's definitely making sure we get off of our phones, and probably more importantly, that we get them up and active. We try to get our kids active for at least an hour of vigorous activity, at least daily. And that for some of our kids that may struggle with weight loss with just those measures, we have something called a healthy lifestyle clinic, which focuses on obesity management for our kids, whether they have inflammatory bowel disease versus not. In that healthy lifestyle clinic, it's not just the dietitians, it's 2 pediatric GI physicians, as well as an exercise physiologist. They do exercises while they're in our office. They get on the treadmill, they do other kinds of fun things to be able to help them with losing weight. And we also do some virtual measures with them also for those patients that cannot come into our specific clinic. The only one thing I would say is that, you know, for some of our kids that they may need to have medication therapy to help with their obesity management. There may be a few kids that may qualify for having surgery, but currently in pediatrics, bariatric surgery is not a recommendation for pediatric patient with morbid obesity.
Thank you, Teri. Whitney, we have a question about mental health screening. Are there any particular questionnaires that you or your office use in your regular practice?
Yeah, thank you, Meredith. So we've used a few different ones over the years. We initially were using the GAD-7 and the PHQ-9, but found that that took a little bit more time in a busy clinic. So we've switched over to using the PHQ-4, which combines kind of key questions from both. And so that's what we've been using lately.
Great, thank you. There's a question about checking the urinalysis as part of health maintenance screening, and the rationale behind that, what we might be looking for when we're doing a UA.
So with the urinalysis as part of health maintenance, we are specifically targeting patients that may be on ASA medicines or mesalamines. ASA medications and mesalamines may increase the risk of having interstitial nephritis. So checking a urinalysis annually is something that's very important. In our practice, we have had 2 patients that developed interstitial nephritis and have actually had to go through with kidney transplants.
Thank you, Teri. The next question is about vaccinations, and I know this is something that we as panelists talked about a little bit in preparation for this, and so it's kind of a couple-part question. But looking specifically at the pneumococcal vaccines, how, Whitney, do you tend to handle things if your patients don't know their pneumococcal vaccine history? And then how do you handle recommending vaccinations, whether that's done through the pediatrician, or do you keep some in your office and administer them, and then following up to make sure that that's been done if boosters are needed?
Yeah, great question, and something that we're actively working on as part of a QI project at my center. So what we've found is that it's sometimes a challenge for our pediatricians to have the Pneumovax 23 available because it's routinely given to an older population, so they don't routinely stock it. So that's been a big challenge. So to kind of help with that, our infusion center was our first place that was really able to easily give the vaccine for all of our patients coming in for infusions, getting the Prevnar and the Pneumovax 23 if needed. To kind of, I don't know if this is across the country, but at least in Pennsylvania, we have a PA state registry where the vaccines are generally entered into. So we can pretty easily track if patients are due for that. If they go to a practice that doesn't routinely enter it, we've been, as part of our QI project, identifying these patients and reaching out to their PCP offices and requesting those records. And also in our clinic, we've been able to work with administration and nursing to be able to provide, in one of our clinics now, kind of starting small, the Prevnar 13 and the Pneumovax 23. So that's something that we found a challenge as well, and something we've been actively working on to improve those vaccination rates.
Great, thank you. Anything to add, Teri? You guys have any different approach?
Well, in our clinic, quite honestly, we do not give vaccines in our clinic, with the exception of the annual flu vaccine and the COVID-19 vaccine for some of our patients. But we do make sure that we share that information with the primary care providers about vaccines that are needed in our patients. We're kind of lucky in that we have Epic as our medical record system, which also will record the vaccines that our patients have had, as well as when they're due for other ones. So it's been sort of a lifesaver for us in trying to make sure that our patients stay up to date with their vaccines.
Mm-hmm. Yeah, it can be difficult, I think, for PCPs to keep track of all the special recommendations. So it's great to be able to pass along specific recommendations for patients. Bouncing over to marijuana use, we have a question about how do you handle that conversation with your patients, Whitney? Do you tend to take a particular recommendation and say, you should or shouldn't do this, or do you give specific recommendations like certain intervals or how often you do it, or do you just kind of talk about pros and cons?
Yeah, I generally kind of review what I talked about in today's session, just kind of the evidence that's available right now. And in Pennsylvania, recreational marijuana is not legalized, but medical marijuana is, and Crohn's and ulcerative colitis are on that list. And so one of the physicians in our group actually has gone through the certification process to be able to recommend medical marijuana. So if someone's really interested in kind of pursuing that, I would refer them to that particular physician to kind of get that additional counseling.
Great. And do you tend to address any other forms of non-inhaled marijuana use, or do you just address it all pretty broadly?
Yeah, pretty broadly, as the data is not the greatest at the time.
Yes. Teri, going back to vitamin D supplementation, do you have a preference or a practice in terms of recommending vitamin D2 or D3 in patients that are insufficient or deficient?
So in our practice, we tend to use vitamin D3. Studies have seemed to show that vitamin D3 may be at least 2 to 3 times more potent than vitamin D2. And oftentimes when we use vitamin D2, that we just aren't making any strides in improving the vitamin D levels. So even with doing our STOS dosing and the studies that I sort of alluded to on the slide that I had, all of those studies, whether they were using 300,000 units of vitamin D or they're doing the 50,000 units of vitamin D, and even the one that used between 100 and 800,000 units of vitamin D, they all use D3.
Great. And you had those helpful charts with the recommended calcium intake as well. When you're talking about that with patients, do you typically talk about them getting calcium from their diet, or will you also recommend a calcium supplement if you're already supplementing vitamin D?
We usually do both calcium and vitamin D together. Many of our kids aren't very tolerant of some of the milk products, so that they may be less likely to get enough calcium in their diet.
Great. I think that's all of the questions from the audience, unless I missed any. If anyone wants to submit one more time, it looks like we probably got them all. But if that is it for questions, we do have a quick 2-minute survey that we would love for everyone to complete. I'm going to put that link in the chat for everyone to do. If you could do it before signing off, that would be wonderful. And I want to thank Teri Jackson and Whitney Gray for presenting tonight, and thank you all for joining us.
Thank you.
I might have gotten one more message.
Thank you.
Hi, everyone. If there's still attendees left, the link for the survey is in the chat box. If you can take 2 minutes to complete, that'd be much appreciated. Thank you and have a great night.